Welcome to the Rad-On Smart Review GYN Cancer Series.
Hello, everyone. Today we're moving into cervix cancer part 4, and this one is all about the practicalities, an EBRT planning workshop.
Exactly. So in the last few sessions, we covered a lot of the why and the when, the background, the staging, the big trials. But now we really need to shift gears to the how. How do we actually deliver this treatment safely and effectively?
Right. It's about taking those guidelines, that evidence, and translating it into a real plan for a real patient. That's the goal today.
So yeah, purely practical. Think of it like we're sitting down at the planning station together. We'll walk through simulation, modern nodal contouring, which is key, justifying why we absolutely use intensity modulated radiation therapy, or IMRT nowadays.
Non-negotiable, really.
Totally. Then how to actually do a simultaneous integrated boost, the SIB approach, getting the IGRT, the image-guided radiation therapy strategy right, and of course managing toxicity.
It's a lot to cover, but it's the core of what we do. And to keep us grounded, we'll use those 2 anchor cases we talked about.
Good idea. Remind us.
Okay, first, our adjuvant case. The 45-year-old woman, post-radical hysterectomy, intermediate risk features. She needs adjuvant pelvic RT, kind of our standard pelvic plan case.
Got it. Standard post-op pelvis.
And second, Mrs. Jackson. 60 years old, intact cervix cancer, FIGO 2018, stage 3 C1R. And crucially, she has those FDG-avid external iliac nodes. So she's getting definitive chemo-RT, and we'll plan her with an SIB.
Perfect. Covers the main scenarios.
Okay, let's dive in. Where do we start?
Has to be simulation and setup. Get this wrong. And, well, everything that follows is compromised.
Right. Garbage in, garbage out. Reproducibility is everything in the pelvis, isn't it? Because things move.
Exactly. So position first, supine, always. And we need reproducible leg support, usually a frog leg setup with vac lock or cushions.
And that's not just comfort, right? It stabilizes things, maybe helps the femurs. Yeah, it stabilizes the pelvis and sometimes rotates the femoral heads a bit laterally, hopefully giving us a bit more wiggle room to spare them later.
Okay. And the scan range, how far up and down?
You got to go high enough and low enough. Scan from the diaphragm that ensures you capture the top of the para-aortic region if you need it later, all the way down to mid-femur. Need to see those full femoral heads for contouring and dose constraints.
Makes sense.
Yeah.
For contrast, yay or nay?
Strongly recommend it, if kidney function allows, of course.
Why so strongly?
Because it just lights up the vessels, the iliacs, the para-aortics, and since we use a vessel-based contouring approach, seeing those clearly makes a huge difference in accuracy. It saves time and uncertainty later.
Okay, good point. Now the big one for pelvis, motion, especially for the primary target.
This is absolutely critical. If you're treating the primary intact cervix, uterus, or even the vaginal cuff post-op, you must get 2 planning CT scans in the treatment position.
2 scans. Why?
One with a comfortably full bladder and one with an empty bladder.
Ah, the full and empty protocol to define the ITV.
Exactly. The internal target volume, the cervix, the uterus, the cuff they float. Their position changes significantly based on how full the bladder is interiorly and how full the rectum is posteriorly.
And we're talking big shifts sometimes.
Oh, yeah. 2 centimeters or even more, superior, inferior, just based on bladder filling alone. If you only plan on, say, the full bladder scan and the patient comes in with a less full bladder,
You could miss the target.
catastrophically miss it. So the ITV from those 2 scans captures that range of motion. But, and this is the clinical pearl, consistency is still key.
Amy.
You still need to coach the patient on trying to achieve that consistent bladder filling each day. The ITV gives you safety margin, but a consistent setup makes OAR, organ at risk, sparing much easier, and the plan more robust.
Got it. Coach consistency, plan for the variability.
Right.
What about markers?
Need a few simple ones. A thin vaginal marker like a radio-opaque catheter or tampon helps define the upper vagina. And then BBs, metal markers at the introitus and the anus.
What are the BBs really for?
They help confirm your field borders inferiorly, make sure you're not cutting off target, and just give you an external check on alignment day to day.
Okay. And image fusion. We often have MRIs and PET scans too.
Right, and fusing them correctly is, well, it's an art sometimes. Generally, MRI is best for the primary tumor detail, the soft tissues. PET-CT is obviously best for flagging those FDG-avid nodes.
So how do you recommend registering them to the planning CT?
There's a specific strategy. First, register the MRI to the CT, but base that registration on the cervix or uterus itself. Optimize the primary target alignment.
Okay, MRI to cervix uterus.
Then register the PET-CT to the planning CT, but base that registration on the bony anatomy.
Why bone for the PET?
Because the nodes, unlike the uterus, are relatively fixed relative to the pelvic bones. So aligning the PET based on bone helps position those nodal GTVs accurately in space.
Makes sense. But what if they don't perfectly align after those 2 steps? MRI can have distortion sometimes.
That's where the manual part comes in. You absolutely have to review the fused images, look at the resulting contours, especially the clinical target volumes or CTVs, and potentially make small manual adjustments. It requires judgment. You prioritize keeping the nodes aligned with bone, but you also ensure your primary target is covered based on the best available imaging. It's not just click and go.
Okay, solid foundation on sim and setup. Now, the contouring itself. This feels like where a lot of the work is.
It definitely is. And we're talking modern, individualized, sculpted volumes now. No more simple boxes.
And where do we get the rules for these sculptures?
We need to follow consensus guidelines. For the post-op case, like our first patient, the NRGR2G postoperative pelvic CDV atlases are the standard.
Okay, and for definitive cases like Mrs. Jackson, or if we're going higher up?
Then the EMBR-ACE to EBRT protocol is really the definitive guide, especially for things like para-aortic coverage.
Let's talk technique. You mentioned vessel-based.
Yes, the core idea is the around-the-vessel method. You identify the major iliac vessels, common, internal, external, both arteries and veins. Then you create an initial volume by expanding, say, 5 to 7 millimeters around these vessels.
But that creates a huge initial volume, right? Includes muscle, bone, bowel.
Exactly. That expansion is just the starting point. The critical step is the editing, the subtraction. You have to meticulously carve that volume off bone, off bulky muscles like the psoas or gluteals, and most importantly, off the bowel.
How do you decide where to stop editing, especially posteriorly near the bowel?
Often you respect the peritoneal lining. You can see it as a fat plane sometimes. Editing back to that helps spare bowel loops, especially higher up in the pelvis. But it's a balance. Edit too much, you risk a miss. Edit too little, you irradiate too much bowel.
Okay, that makes sense. Now, making sure we cover all the right areas electively. That CIEOP mnemonic you mentioned.
Ah, yes, CIEOP. It's just a way to remember the 5 key pelvic nodal basins for standard coverage.
Let's hear it again.
C is for common iliacs, I for internal iliacs, E for external iliacs, O for obturators, and P for presacrals. CIEOP covers the main pelvic stations.
Okay, CIEOP. Let's zoom in on O and P, obturators and presacrals. Those can be tricky.
They can be. For O obturators, you have to remember it's not just the nodes high up near the vessels. You need to follow that corridor down. The inferior and parasymphyseal obturator space, sometimes quite close to the pubic bone, easy to undercut that inferiorly if you're not careful.
Right, get the whole chain. And P, presacrals, that's a common question area.
Definitely board relevant. The presacral CTV is basically a slab about 1 to 1.5 centimeters thick, lying just anterior to the sacrum. Superiorly, it goes up to the aortic bifurcation where the common iliacs start.
And the inferior border, that's the key point.
The inferior border needs to extend down to the S2 to S3 level. Stopping at S1 is a common mistake and risks missing the lowest presacral nodes.
Is there a good practical landmark on CT for S2, S3?
Yes, a really useful one. Look for the first axial CT slice where the piriformis muscle starts to appear posteriorly in the pelvis. That's roughly the S2, S3 level. That's your cue to stop the presacral contour.
Perfect. That's very helpful. Okay, what if we have positive nodes higher up, like common iliac involvement, like maybe Mrs. Jackson might develop? Do we need to go into the para-aortic region?
Yes. If elective para-aortic nodal coverage is indicated, usually driven by common iliac positivity or very high pelvic nodes, then that CTV has to extend superiorly quite a bit.
How high?
The standard endpoint now, based on EMBR-ACE2, is the crural confluence, where the diaphragmatic crura meet the aorta. That's typically around the T12 vertebral body level.
Wow, that's quite high.
It is. And you follow the aorta and vena cava up to that point. And importantly, treating this extended field, this para-aortic chain, is really only feasible and safe because we use IMRT now.
Right. The old EFRT, extended field radiation therapy with 3D techniques, had horrendous toxicity, didn't it?
Crippling bowel and kidney toxicity, IMRT allows us to sculpt the dose away from those organs much more effectively, making para-aortic treatment actually deliverable.
Okay, one more CTD point. The primary target for an intact case like Mrs. Jackson, it's much bigger than the post-op cuff volume, isn't it?
Oh, absolutely. For the definitive case, the primary CTV includes the gross tumor volume, or GTV, if visible, plus the entire cervix, the entire uterine corpus, the bilateral parametria all the way out to the pelvic sidewalls, and the upper two-thirds of the vagina. It's a large volume.
And does that volume change based on local spread?
Yes, you have to account for invasion seen on MRI. If there's posterior extension, you might need to include the mesorectum. If the disease involves the lower third of the vagina, that's a specific indication to add the inguinal nodes to your elective CTV.
Got it. That covers the what and where of contouring. Now, let's talk IMRT. We've hinted at it, but why is it really the standard? Sometimes, a four-field box seems quicker, simpler.
I hear that argument, but frankly, it's outdated and not justifiable anymore from a patient safety standpoint. Planning speed cannot trump minimizing long-term harm.
So the justification isn't just, it looks prettier.
Not at all. It's based on solid level 1 evidence from randomized trials showing clear benefits in reducing toxicity. Using a 3D four-field box today for routine pelvic RT is arguably below the standard of care because we know IMRT is safer.
Okay, lay out the evidence. Which trials do we need to quote?
There are two key ones. First, for acute toxicity, you need to know the TIMEC trial, which was also NRGR-TOG 1203.
TIMEC, what did it show?
It looked specifically at adjuvant pelvic radiation after hysterectomy, comparing IMRT to 3D. The main finding was significantly less patient-reported acute GI toxicity with IMRT. Less diarrhea, less cramping. Patients just felt better during treatment.
Okay, better acute tolerance. That's important.
It is, but arguably the late toxicity data is even more compelling because those are the problems that can last for years. And that brings us to the PARCER trial.
PARCER. What was the key finding there?
PRCR looked at late effects, again comparing image-guided IMRT versus 3D for post-op pelvic RT in GYN cancers. It demonstrated roughly a 50% relative reduction in late grade 2 or higher GI toxicity with IMRT.
50% reduction in serious late bowel problems.
Exactly. Things like chronic bleeding, strictures, obstructions, fistulas, the really life-altering complications. Cutting that risk in half is a massive clinical benefit. You simply can't ignore that data.
So going back to that analogy, 3D is the broad chisel.
Yeah, it paints the dose broadly, hitting a lot of normal tissue, especially bathing the bowel in low dose.
Whereas IMRT
is the sculptor's tool. It uses multiple beams, thousands of tiny modulated beamlets, to precisely conform the high dose to those complex CTVs we just talked about, while actively carving dose away from the small bowel, the bladder, the bone marrow. That normal tissue sparing is the whole point.
Makes the case pretty clear. Okay, so if we're using IMRT, we need to respect OAR constraints. Let's talk numbers. Where do we start? Maybe bone marrow, especially for Mrs. Jackson on chemo.
Absolutely essential for concurrent chemoradiation cases. Cisplatin is tough on blood counts. If you blast the pelvic marrow with too much radiation, you'll cause severe neutropenia or thrombocytopenia.
And that forces treatment breaks, right? Stops the chemo.
Exactly. You have to hold the cisplatin, potentially compromising the cure. So sparing active bone marrow is a primary planning goal.
Is there trial data backing specific constraints?
Yes, the INT-ERT EC2 trial. It showed that using techniques to spare functional marrow, often guided by PET or specific CT definitions of active marrow, significantly reduced grade 3 or higher hematologic toxicity.
So what are the key numbers we need to hit for boards and for practice?
The main ones to remember for active pelvic marrow are V10, the volume getting 10 gray, should be less than 90%. And V20, volume getting 20 gray, must be less than 75%. Meeting those really helps patients get through their cisplatin.
Okay, V10, 90%, V20, 75%. Got it. What about the small bowel?
Always a challenge. The classic constraint we watch is based on the Quantec data, focusing on high dose to prevent late obstruction or perforation. That's the V45 volume getting 45 gray, should be kept below about 195 CCS.
V45, 195 cc. Is that the only bowel constraint we care about?
It's the main one for severe late effects, but many centers also track the low-dose bath, as you mentioned. For instance, aiming for a V15 volume, getting 15 gray, less than or equal to maybe 120 CCS. This might correlate better with acute diarrhea and cramping during treatment. It's more of a planning heuristic, but a useful one.
Okay. Now, the ones that move with the target rectum and bladder?
Yeah, these are often the planning bottlenecks, especially in definitive cases where the cervicuterus ITV pushes right up against them. For the rectum, a common goal is V45 less than 50%. But you also watch the max point dose carefully, trying to keep it below, say, 52 gray if possible, though the target coverage might push that.
And the bladder, which causes all that ITV variability.
Similar idea. We often aim for V40 less than 50% and maybe V45 less than 35%. But again, the challenge is that the ITV might overlap significantly, and if the patient's bladder filling isn't consistent day to day, the actual dose received by the bladder wall can vary quite a bit from the plan.
Underlines the importance of that consistent filling again. Lastly, femoral heads.
Need to protect those. Osteonecrosis is a nasty complication. The risk really starts climbing above 52 gray and gets significant by 65 gray. So the goal is simple. Keep the B50 minimal, essentially 0 if possible, and keep the max dose as low as reasonably achievable. Definitely aim below 50 grays, especially in the post-op setting without a boost.
Okay, that covers the main OARS. Now, back to Mrs. Jackson. She has positive nodes needing a higher dose. How do we handle that with the SID approach?
Right, the simultaneous integrated boost. This is for cases like hers with FDG avid gross nodes in the pelvis. We need to get a higher dose to those involved nodes, but we want to do it concurrently with the elective pelvic treatment.
Why concurrently? Why not just treat the pelvis then boost later?
Because overall treatment time matters, especially before brachytherapy. We need to keep the external beam phase relatively compact, usually around 5 to 5.5 weeks, to allow a timely transition to the brachy boost, which is crucial for the primary tumor cure. SIB lets us dose escalate the nodes without extending the EBRT duration.
Smart. So what's the typical dosing?
You give the elective pelvic CTV covering CIEOP a dose like 45 to 48.6 gray. And simultaneously, the PTV around the involved node or nodes gets boosted to a total dose of, say, 55 to 60 gray. A common fractionation is 58.05 gray in 27 fractions total, delivering 2.15 gray per fraction to the node, while the elective pelvis gets 1.8 gray.
Okay, 55 to 60 gray total to the node PTV. But that PTV is often right next to bowel or bladder or, critically, that active bone marrow we just talked about sparing. How do you deliver nearly 60 grays there without violating those marrow constraints?
That is the central challenge of SIB planning. You absolutely must prioritize meeting those marrow constraints. V20 less than 75%, V10 less than 90%. You cannot compromise the patient's ability to get chemo.
So what gives? How do you make it fit?
It requires highly conformal planning, very tight PTV margins around the node, maybe even using a planning risk volume or PRV approach for the marrow to force the dose away. Sometimes you have to accept that the dose within the nodal PTV isn't perfectly uniform, maybe a small hot spot in the middle, or you accept slightly less coverage at the very edge of the PTV margin if that's what it takes to spare the marrow or the bowel V45. The OAR constraints, especially marrow, often take precedence over perfect target coverage in these tight spots.
That's a critical point. Marrow sparing trumps hitting the absolute prescription dose sometimes.
Yeah.
Okay, plans done, constraints met. Now we treat IGRT as essential, right?
Mandatory, absolutely mandatory with these highly conformal IMRT plans. The dose gradients are so sharp, meaning the dose drops off very quickly outside the target. A small setup error of just a few millimeters, if uncorrected, could lead to underdosing the target or overdosing an OAR day after day.
So what's the standard technique?
Daily cone beam CT, or CBCT, performed just before treatment delivery, with online correction meaning you adjust the couch based on the CBCT alignment before turning the beam on.
Okay, daily CBCT, but what do you match to? This seems crucial for a plan covering both the mobile primary and the fixed nodes.
It is crucial, and there's a specific strategy largely guided by the EBRT E02 protocol. It's a dual-goal approach. Goal number 1, the primary alignment goal, is you must match to bony anatomy.
Match to bone. Why not match to the tumor or the cervix? Especially if there are fiducial markers in place. Wouldn't that be more accurate for the primary?
That's the common question, and it seems counterintuitive at first, but think about the geometry. The largest volume receiving potentially high dose, especially with an SIB, is often the elective nodal CTV and the boosted nodes. These targets are fixed relative to the pelvic skeleton. The primary tumor, or the cervix with fiducials, is mobile due to bladder and rectum filling. If you chase that mobile target by matching to fiducials, you will inevitably shift the entire treatment field relative to the bones.
And that risks misaligning the nodal targets.
Precisely. You could systematically underdose your elective nodes or overdose adjacent OARS near the nodes because the whole field shifted to follow the cervix. So, rule 1. Align the field based on bony anatomy to keep the fixed targets properly registered.
Okay, match to bone first. What's the second goal then?
Goal 2 is after applying the bony correction, you then verify ITV coverage of the primary target on the CBCT. You check that the mobile primary target, cervix, uterus, cuff, is still adequately contained within the planned ITV contour.
So, bone match for alignment. Then check the ITV covers the moving target. What if it doesn't? What if the ITV seems inadequate on the daily CBCT, or maybe the bladder or bowel looks much worse than planned?
First, you don't just treat. You stop and troubleshoot. Can the setup be improved externally? Try recoaching the patient on bladder filling. Maybe have them drink more water or empty their bladder and then rescan.
What if that doesn't work? Or if it's a consistent problem day after day?
If the deviation is significant and persistent, maybe the tumor has shrunk a lot, changing the internal geometry, or the patient just cannot achieve consistent filling, then you have to consider more systematic plan adaptation. That might mean replanning on a new CT or even adapting the plan based on the CBCT itself. It's complex, but sometimes necessary.
Okay, that clarifies the IGRT process. Let's bring it all together now with our cases. Apply this thinking. Case 1, the 45-year-old post-op intermediate risk.
Right. Her plan. Adjuvant image-guided IMRT standard dose, maybe 45 to 50.4 gray in 1.8 gray fractions.
Oh, yeah.
Vessel-based CIEOP contours using the NRG Atlas guidance. Presacrals correctly down to S2, S3 at the piriformis level.
IGRT.
Daily CBCT, matched to bony anatomy. We verify cuff coverage within the ITV if we generated one from dual scans, which is ideal even post-op.
And the justification for IMRT in her case.
Purely toxicity reduction. We quote TIMEC for lower acute symptoms and, more importantly, PARCER for that 50% reduction in late grade 2 plus GI toxicity.
Okay, let's troubleshoot her plan. Say during planning, her max femoral head dose keeps hitting 60 grays. What's the first move?
Femoral heads are fixed OARS. 60 gray is too high. First, try planning tricks. Can you use more beams, different angles, optimize the fluence better to carve dose away? If that fails, you might have to slightly tighten the PTV margin right next to the femoral head, specifically around the external iliac node CTV. It's a small compromise on margin to avoid a major risk of osteonecrosis.
Makes sense. Now, case 2, Mrs. Jackson, definitive stage 3C1R, positive nodes, getting chemo.
This is the complex one. Definitive chemo RT with weekly cisplatin. The plan is an SIB approach.
Dosing again.
Elective pelvis, say, 48.6 gray in 27 fractions. Simultaneous boost to the nodal PTV up to around 58 gray in those same 27 fractions.
Key constraints.
Absolute adherence to bone marrow, V10, 90%, V20, 75%, and respect the Quantex small bowel V45 limit, less than 195 cc.
Okay, troubleshooting Mrs. Jackson's SIB plan. First plan check, the pelvic marrow V20 is 80%. It's over the 75% limit. What do? You can't just approve it.
Absolutely not. Violating the marrow constraint jeopardizes the chemo. You cannot relax the marrow constraint itself. So the move is aggressive dose sculpting.
Now,
first, create strong avoidance structures on the marrow, maybe use PRVs. Push the optimizer hard to pull dose away. If that's still not enough, you look at the other OARs, bowel, bladder, rectum. Are they also extremely tight, or is there any room? If everything is tight, the last resort might be to accept slightly less dose homogeneity within the elective CTV. Maybe allow a colder spot in a low-risk area to ensure the SIB dose gets delivered while desperately protecting that marrow. You prioritize the marrow and the gross disease boost.
Tough choices. And her treatment path after EBRT.
Daily CBCT, using the bone match. Verify ITV coverage strategy. Complete the EBRT course, monitor counts weekly, and then, critically, transition immediately to image-guided brachytherapy to boost the primary cervix tumor. No gaps.
Great synthesis.
Okay.
Planning is done, treatment's running, but patients experience side effects. We need a proactive toxicity management plan. Let's run through the common acute issues. GI first, diarrhea, cramping.
Yeah, pretty much expected, especially with cisplatin adding to the pelvic radiation effect. The key is being proactive.
Okay.
Start scheduled loperamide, don't wait for it to get bad, titrate the dose up.
What if loperamide maxes out?
Escalate to diphenoxylate atropine, Lomotil. And crucially, from day 1, emphasize hydration and a low-residue diet, avoid high-fiber, greasy foods, etc. Dehydration and electrolyte imbalance from diarrhea can force treatment breaks, so managing it early is vital.
Okay. GU symptoms, frequency, urgency, maybe burning.
First step, always. Urinalysis. Rule out a UTI, which presents identically. If it's negative, it's likely radiation cystitis. For dysuria, phenazopyridine, pyridium, can provide good symptomatic relief. And again, hydration helps dilute urine, making it less irritating.
Hematologic toxicity, the big risk of chemo-RT.
Yes. The marrow-sparing IMRT helps a lot, but you still must check a CBC weekly. Have clear institutional thresholds for holding cisplatin, typically an absolute neutrophil count, ANC, below 1,000 or 1,500, or platelets maybe below 75,000. The goal is almost always to continue the radiation if possible, even if chemo needs a delay or dose reduction. Radiation is the backbone here.
Right. Nausea and vomiting from the cisplatin, CINV.
Cisplatin is highly immunogenic. Standard prophylaxis is usually a 2-drug combo, a 5-HT3 antagonist like ondansetron plus dexamethasone, given before chemo.
Well, if that's not enough.
If they're high risk or having breakthrough nausea, consider adding a third agent, an NK1 receptor antagonist like aprepitant.
Skin reaction, dermatitis in the field.
Usually manageable. Gentle cleansing with mild soap and water. Pat dry, don't rub. Wear loose, moisture-wicking fabrics. A barrier cream like zinc oxide can help. Or a mild topical steroid like hydrocortisone if it gets itchy or inflamed.
And fatigue, everyone gets tired.
Yeah, universal. First, normalize it, let patients know it's expected, check their CBC to ensure anemia isn't contributing significantly. And then, counterintuitively, encourage light activity like short walks. It often helps combat fatigue better than just resting all day.
Good tips for acute phase.
Yeah.
What about the long term, the late toxicities we worry about months or years later?
Important for survivorship counseling. Chronic bowel issues, ongoing diarrhea, urgency, maybe bleeding. Management involves long-term dietary changes, maybe continued loperamide, or sometimes bile acid sequestrants if bile acid malabsorption develops. And this is where that PAR-CER trial benefit really shines fewer patients needing these interventions.
Pelvic fractures.
Pelvic insufficiency fractures. Definitely counsel patients that new onset hip, buttock, or pelvic pain months to years later needs evaluation. It's often a fracture. Consider a DEXA scan baseline, optimize vitamin D and calcium intake. It's becoming recognized as a common late effect.
Sexual health is a huge quality of life issue.
Absolutely. Often underaddressed. Need to proactively initiate discussion about vaginal dilator use, usually starting 4 to 8 weeks after all treatment finishes, to prevent stenosis and maintain vaginal capacity. Counseling on lubricants and referral to pelvic floor PT can be incredibly helpful.
And lymphedema.
Risk is lower with IMRT compared to older surgery plus radiation approaches, but still exists, especially if inguinal nodes were treated or extensive pelvic surgery occurred. Key is early detection and referral for management compression garments, manual lymphatic drainage, exercise.
Excellent overview of toxicity management. Ready for a quick board review round?
Let's do it. Fire away.
Okay, question 1. Contouring focus. When drawing the presacral nodal CTV, what's the correct inferior border level? What's the CT landmark?
Inferior border is S2 to S3. The landmark is the first axial CT slice showing the piriformis muscle.
Correct. Question 2. Trials. Which randomized trial demonstrated about a 50% relative reduction in late-grade 2 or higher GI toxicity when comparing IMRT to 3D for post-op pelvic RT?
That's the para-aortic trial. Key justification for IMRT.
Perfect. Question 3. Constraints for chemo-RT. For a patient getting weekly cisplatin, which bone marrow constraints are critical for reducing hematologic toxicity and which trial supports them?
Need to keep V20 less than 75% and V10 less than 90% for the active pelvic marrow. Validated by the INTERT ECC2 trial.
Excellent. Nailed all 3. Let's wrap up with a few key clinical pearls summarizing today's workshop.
Okay. Pearl number 1, I think, has to be the IMRT justification.
Go on.
To really make the case, you need to be able to cite both TIMEC for the reduction in acute patient-reported symptoms and PICR for that major reduction in severe late GI toxicity. Knowing both strengthens the argument.
Good point. Pearl number 2.
Pete, the IGRT matching strategy for these complex pelvic plans. Remember the dual goal from EBRT, daily CBCT. Correct a bone first to align the fixed nodal targets, including NESIB. Then verify that the ITV still covers the mobile primary target. Don't chase fiducials if it misaligns your nodes.
Critical distinction. And a final pearl.
Let's go back to contouring. Remember the CIEOP vessel-based approach, 5-7 millimeter expansion, then edit. Pay special attention to getting the full extent of the obturators, inferior parasymphyseal corridor, and the presacrals down to that S2, S3 piriformis landmark. Avoid those common geographic misses.
Fantastic pearls. Really sums up the technical execution.
So today we really got into the weeds of external beam planning for cervix cancer. We went through simulation, contouring based on guidelines, the solid evidence behind IMRT, OAR constraints like marrow sparing, the SIB technique, and that crucial IGRT strategy.
Yet we cover the how in detail, grounding it all in trial data and practical tips for managing toxicity. It's a foundation for the next step.
Exactly. And that next step is arguably the most critical part of achieving cures in locally advanced cervix cancer. So next time, join us for Cervix Cancer Part 5, Brachytherapy, where we'll delve into the techniques and importance of the brachy boost.
Looking forward to it. Remember, you can complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review to catch our next episode on brachytherapy. Thanks for tuning in.